Entrapment of the median nerve in the carpal tunnel region is the most common entrapment neuropathy. Nocturnal paresthesias in the hand are the most common initial clinical presentation. Patients also complain of numbness in the hand, clumsiness, pain in the hand and forearm, and weakness or atrophy of the thenar eminence. Conservative measures, including modification of work activities, splinting of the wrist in the neutral position, anti-inflammatory agents, and steroid injections, are quite effective in mild cases. Surgical intervention should be considered for cases which continue to be symptomatic despite conservative measures. Surgical release of the transverse carpal ligament was first described by Sir James Learmonth in 1933. The standard open carpal tunnel release procedure is a very safe and effective treatment for this disorder, with most series reporting well over 90% success. More recently, several different endoscopic procedures have been described for surgical division of the transverse carpal ligament. While these procedures are very effective in experienced hands, there is a very steep learning curve with reports of disastrous complications. The procedure that we demonstrate here is the so-called mini open carpal tunnel release. With experience, the transverse carpal ligament may be divided completely through a skin incision which measures from 1.5 to 3 cm, depending on the individual patient's anatomy. Success of the procedure depends upon meticulous technique with attention to certain important anatomic details. We prefer to perform the procedure under local anesthesia with some mild sedation. A tourniquet is optional, and we prefer not to use one. The patient is positioned supine with the arm abducted on a hand table or arm board. After a sterile prep and drape, the incision is marked along the ulnar border of the major thenar crease in line with the radial border of the ring finger. The incision begins just distal to the distal wrist crease and extends to Kaplan's line, which extends along the distal border of the outstretched thumb down obliquely toward the pisiform. Local anesthetic is injected, and the incision is made with a number 15 blade. We start with a small Heiss retractor, and meticulous hemostasis is maintained with the bipolar. We prefer to dissect with a fine instrument such as a Jacobson or a flat dissector, continuing sharply down to and through the transverse carpal ligament. The palmar fascia and then the palmaris brevis muscle are divided. A small Wheatlander retractor is placed for the deeper aspect of the dissection. The transverse carpal ligament is visualized and progressively divided sharply. It is important when using a short skin incision to have your assistant retract on the skin edges both proximally and distally in order to optimize the exposure. We use loop magnification and often a headlight for this procedure. Once the edge of the transverse carpal ligament is clearly visualized and the underlying median nerve well seen, a small sharp scissors can be used for completion of the division of the transverse carpal ligament. Here we use a tenotomy scissors for this purpose. This dissection should be performed under direct vision. Here the assistant works distally until the distal edge of the transverse carpal ligament is visualized. Fat is seen at the distal end of the ligament, indicating the presence of the vascular arcade. The motor branch of the median nerve is often visualized and must be carefully protected. We like to palpate in the incision to be sure that no remaining areas of compression are identified. The wound is then irrigated and meticulous hemostasis is obtained with the bipolar. It is very important during the closure to avoid closure of the transverse carpal ligament, which would defeat the purpose of the operation. We place a few subcutaneous sutures of 3/0 Vicryl to reapproximate the wound, and then close the skin with interrupted or running simple 4/0 nylon. Vertical mattress sutures may be used as needed. Once again, we are reviewing the location of the incision. If the incision has to be extended proximally, we prefer to cross the wrist crease with a short S-shaped incision. We use a bulky, soft dressing and encourage early mobilization of the fingers. The skin sutures are usually removed on postoperative day 10. Occupational hand therapy may be recommended. These are all outpatient procedures which may be completed in 15 to 30